Good afternoon, everyone. I would like to introduce you to Michelle Tong. She is with the State Department of Health, and they will be doing a stroke education prevention presentation and doing a one-year checkup or follow-up with Lanakila Senior Center members who provided information a year ago about their vitals, and then now seeing if there was any change based on behavioral changes in their health status. So thank you so much, Michelle, for being here.
Thanks,
and I know you'll introduce the others. Thank you.
So the person that has the same background as me, that's Chelsea. She works with me, Department of Health Neurotrauma Program. And then on the other side with the fun glasses, this is Danae. She is from Queens Medical Center, and she's our special guest. She's a nurse and a stroke coordinator over at Queens. So she knows all the good stuff going on. Susie, do you think, are we expecting anybody else?
You'll see Jean Sugiyama, Diane Kawakami, and Iris Hiromoto on one.
Yep.
I'm not too sure. I'm sure people will continue to add on. Marilyn DeRoche just came on. Hi,
Susie?
Marilyn. Hi, Adele. Yes.
I think I was initially logged on using an old link from a previous presentation. So I was waiting and waiting.
Yeah,
And
sorry
then
about that.
I saw your latest email about see you soon. And then I checked and oh.
Yes, because the
Oh,
Department of Health created the Zoom link for this meeting rather than the Lanakila Senior Center. So I'm so sorry it's late.
No,
yeah, thank you.
It's not your fault. It's just.
I'm so sorry.
Thank you all
It
for
is
being here. We wanted
Thank you,
to
Michelle.
do our Zoom because we have something special for you guys today. So I am going to go ahead and get started. Oh, wait, let me open up. Hold on just a second here.
I do want to thank Michelle because she's been so diligent about collecting our information. I know it takes a lot to enter everything, last year, and now having to enter everyone's information again. So we really appreciate this partnership and Michelle's diligence. Thank you.
Thank you so much. I have to tell you, it's kind of fun doing it. It's fun to see the numbers and see how they work out and stuff. The only thing is, I wish, but this is the first time we had it. So Susie, thanks for having faith in us and really taking a chance on us doing this. I mean, it seems like a little thing, but everything has to start somewhere, right? And this is the first time we've done this program and tried to extend it, work to extend it over a year and get feedback on what's going on. So we didn't get as many people responding back after a year as we would have liked, but it's a good first start.
Thank you.
No, thank you. So again, thanks for having us. If you're new or if you forgot us from last year, Chelsea and I are from the State Department of Health Neurotrauma Program, and we assist survivors of traumatic brain injury, spinal cord injury, and stroke. We have a helpline that survivors, families, or caregivers can call, or people just want information or resource referrals. Our contact information will be at the end of our part of the presentation, but also if you need us or if you have, a need to contact us, Susie also has our information, so anytime. So this particular campaign is generated from the American Heart, American Stroke Association's education campaign, I Will Not Have a Stroke or I Will Not Have Another Stroke. So today is going to be a refresher on stroke information and look at your activities as a group that you did in the last year to reduce your stroke risk. We will review some basic stroke knowledge, risk factors, and what you can do to control your risk level. We'll compare your group's 2021 to 2022 results, and we'll discuss how to identify a stroke and what to do if someone is having a stroke. And Danae from Queens, you already met her, will come on. She's our special guest. She is going, see, the folks that aren't here are going to miss out because Danae has a front seat to the innovation in stroke care. So you will know by the end of this presentation, if someone that you care about or yourself is having a stroke, what they can expect and the best action to take. So that is ACEs. All right, so the first thing that we want to do is we want to have you answer a poll and find out what you already know about stroke. So Chelsea put up the poll, and if you can just pick one response and then hit submit. Please finish this sentence. An ischemic stroke is caused by A, a blockage in an artery, B, a seizure, or C, a blow to the head. Seven people responded. I think one more person. 9, there we go. Okay, so Chelsea is sharing the results. You guys did awesome because you're right. It's A, a blockage to an artery, and that's the correct answer. And this causes an ischemic stroke. And as you can see in the picture, a large clot is not allowing blood to circulate. So if blood can't get to your brain, then your brain will be deprived of oxygen. About 74% of all strokes are ischemic. The other kind of stroke is hemorrhagic, and that makes up about 20%. And this is when the head is hit by or against something usually, or there's a tear in the vessel. The remaining 6% of strokes are known as transient ischemic attacks, and they are mini strokes. Mini strokes are a warning sign that if left untreated, you or the person with the mini stroke will have a very high likelihood of having a full-blown stroke within a year. So our next poll, Chelsea just put it up. What is the #1 risk indicator for stroke? Is it A, diabetes, B, smoking, or C, high blood pressure? So which one of these things is the highest, has the highest correlation of the likelihood you're going to have a stroke if you do or have one of these things? 6 people answered so far. 7, 8, 'Can we get one more response? There we go. All right. So thank you. The correct answer is high blood pressure. So in 2005, American Heart Association journals published findings from medical researchers who followed 27,936 people for 6 years. From that group, they found that 90% of the people that experienced a stroke had high blood pressure. So that's really important to get your high blood pressure under control. Our third poll, what is the most effective way to reduce your stroke risk? A, practice mind control. B, improve dietary choices and engage in regular physical activity. Or C, monitor your blood pressure every day. We have 7 people, 7 responses so far. Man, you guys are awesome. So yes, the correct answer is improve dietary choices and engage in regular physical activity. So you want to do more of, vegetables and fish and getting around, and less, French fries, donuts, soda, and being a couch potato. If you chose C, nobody chose C. Monitoring your blood pressure every day is good, but it's doing these actual physical things that are going to change your stroke risk. So now I'm going to hand it over to Chelsea, and she's going to go over our stroke risk scorecard.
Okay, thank you, Michelle. So just a quick review of the 8 factors that affect your stroke risk levels. So blood pressure, as Michelle mentioned, is the #1 indicator for stroke risk. So make sure to get it checked and work with your doctor if it is high or borderline to try to get it under 120/80. Atrial fibrillation, your risk of developing atrial fibrillation increases as you get older. Smoking, using tobacco products can contribute to a buildup of plaque in your arteries. Cholesterol, we want to keep our LDLs or bad cholesterol under 200 if possible to minimize our risk for stroke and other cardiovascular diseases. Diabetes, also type 2 diabetes contributes to cardiovascular diseases and can increase a person's risk. Physical activity, aerobic activity has been shown to benefit blood pressure, reduce LDLs, reduce inflammation, and control sugar and weight. So the National Institute of Health found that those who are underweight are almost 20% more likely to have a stroke compared to those who are healthy weight. And this percentage more than doubles for those who are overweight. And then family history. So this is the only risk factor that we don't have control over, but if you do have a family history of stroke, it's a good reason to pay closer attention to the other 7 risk factors. Okay, so now we're going to compare what folks reported last year to what they reported this year. And so keep in mind that the 2022 results have a handful of people who participated this year but didn't participate last year. And then some people who participated last year didn't provide us with the results this year. So the results are not a direct comparison, but we're hoping, this would give us kind of a general idea of where folks are at last year compared to this year. So for blood pressure and atrial fibrillation, it looks like the percent in the low risk category increased, which is good, and the percent in the high and caution categories decreased. Okay, looking at smoking. So it looks like 100% of people who reported this year are non-smokers, which is great. And for cholesterol, the same percentage reported low risk, and the caution risk level increased, but the high risk level percentage decreased. So still doing great so far. And for the diabetes and level of physical activity, it looks like the percentage of low risk increased, the percentage of caution decreased, and the percentage of those with high risk for diabetes increased, but the high risk level for physical activity decreased a bit. So, okay, and then moving on to weight and family history of stroke, it looks like the percentage of low risk slightly increased, the percentage of caution stayed about the same, and the percentage of high risk decreased for both factors, so that's good. And then, okay, and so finally, looking at overall stroke risk from this year compared to last year, it looks like the percentage of low risk increased a pretty good amount, the percentage of caution decreased, and the percentage of high risk slightly increased. But overall, good job, everyone, and thank you for participating. And this year or last year. So even if you haven't completed a survey, we hope that these results will kind of provide everyone with some information on where you are relative to other people. Okay, and so the next results we're going to go over is the stroke awareness, the activities that people said they wanted to work on last year, and what people reported working on in the past year. So the left-hand column shows the percentage of people who said they wanted to work on these risk factors in 2021. And then the right hand is the percentage of people who said that they did work on these risk factors within the past year. So it looks like almost the same percent of people who wanted to work on their blood pressure did, and a slightly higher percentage worked on quitting smoking and lowering their cholesterol and blood sugar and weight. And about the same percentage, 50%, said they worked on increasing physical activity. About 17% reported they didn't work on anything in the past year. And that could be because maybe their risk level was low, or maybe they were just busy, but it looks like most people who completed the survey this year worked on something in the past year. So that's good. And then here's some additional pledge results. So again, the left column is activities that were pledged last year. And then the right column is the percent of this year that reported working on these in the past year. So it looks like a slightly lower percentage reported exercising, checking their blood pressure, cholesterol, sugar. About the same percentage reported eating healthier and working on quitting smoking, was a little higher. Last year, about 3% said they were not planning to do anything, and about 13% reported not doing anything this year. So, and this isn't on the slide, but the people who responded to the survey this year, approximately 50% said they felt successful or partially successful in working to reduce their stroke risk in the past year. And the other 50% either didn't respond to this question, or they didn't participate last year, or maybe they were not able to work on reducing their stroke risk because maybe it was low, or maybe people are busy, and it's not an easy thing to do to make these choices, and it really is up to each person to make these choices, because no one else can really do it for you. You have to be the one usually. Okay, so moving on, we wanted to just review some statistics on stroke. So it's the 5th leading cause of death in the US and the 3rd leading cause of death in Hawaii. It's a leading cause of chronic disability. About 3,500 people per year seek medical treatment for stroke in Hawaii, and about 3% of adults in Hawaii reported that they've been told by a healthcare provider that they have had a stroke in the past. And then for every minute that during a major stroke, a major large vessel occlusion stroke, about 1.9 million brain cells die. And so, it's kind of hard to imagine, like, what does that mean? But if you relate it, it means the brain ages 3 weeks per minute, or 3.6 years per hour that your stroke goes untreated. So yeah, very important to get treatment quickly. And so we're going to do the last poll for now. And it's, what would you do if you had a stroke? A, drive myself to the hospital. B, wait and see if it gets better. C, ask someone else to drive me to the hospital. Or D, call 911. Okay, great. So very good. Everybody got it correct. So Danae will be going over this in more detail, but we really want to encourage everyone to call 911 rather than driving themselves to the hospital, because the treatment will start once the ambulance gets to you, and they can give the hospital a heads up that you're coming so they can get ready for you, and EMS staff are trained to take you to the nearest hospital that can provide appropriate treatment. Okay, so if somebody has a stroke, or if you recognize that somebody has a stroke, and Danae will be going over the BFAST acronym to kind of identify if you or somebody else is having a stroke. You want to do 3 things. You want to call 911, and then note the time of symptom onset, because this will be very important, because certain stroke treatments can only be administered within a certain time from when the symptoms started. So your doctor will want to know this, and then also make a note of any medications that person is taking, or bring them with you. And Danae, I think, can go over that too a little bit more. And so here's our contact information. I'm going to turn it over to Danae right after this, but does anybody have any questions right now? Okay, yeah, so if not, here is Danae. Thank you.
Hi guys. Did anyone have any questions before I start?
Do they recommend giving a baby aspirin if you have symptoms of stroke?
So no, we would want you to get assessed before doing that, because there are 2 different types of strokes, and one of them is a bleeding stroke. And so if you took aspirin and your brain was bleeding, you would make it worse. So, and then when you come in, you actually need something typically much stronger than aspirin to break up that clot if you're having a blocking stroke or an ischemic stroke. So the first thing you should do is call 911 so that you can have a neurologist actually determine what kind of medication you require. That's a really good question though, because I definitely see it.
I think we've been told to take aspirin. So I'm glad Marilyn asked that question.
Yeah, I think, if some people are prescribed aspirin daily, as a stroke prevention, but if you're having a stroke, that's when that treatment changes. Are you guys seeing 2 screens or 1 right now? Like 2 of my slides or 1? 2, okay.
2. One has systems of care in Hawaii and the other is Queens Medical Center punch bowl and a
Okay.
triangle.
Like figure out how to make it share the right way. Just do screen 1, share, and then I'll swap. Now just 1?
Yes.
Okay.
Yes.
Cool. Okay, so we're just going to talk about different things with stroke care in Hawaii. First, I want to just point out that there are different types of stroke centers, different hospitals. This is the same for the mainland. It has to do what their capabilities are for strokes. So Queens Medical Center is a comprehensive stroke center. That's the top type of recognition for stroke care you can get. And then Castle, Hilo, and Wilcox are primary stroke centers. And then I would say every other hospital in Hawaii is an acute stroke ready hospital, meaning you can get stroke care there. You just, they probably just don't even try to get certifications, but you can get the treatment there. In the state of Hawaii, we have the Hawaii Stroke Coalition, which is a conglomerate of all these different organizations. It includes, Queens, HPH, Kaiser, RHOP, Hilo, the Castle Medical Center, Maui Health, and then City and County EMS. This is where we all meet and try to figure out how can we make sure that we're providing the best care for patients in Hawaii, no matter what organization we are. We really take a focus of working together to pool all of our resources and less as a competitor. So I'm proud to say I'm on this board. And then you might say, okay, I'm having a stroke. What is the treatment? Like, why do I go to the hospital? And you go to the hospital because there's 2 kinds of treatments for that blocking type of stroke, the ischemic stroke. And like they said, that's the one that's most common. So the interventions that were developed are relatively new, as in they've only been around since the 1990s. And so, for some of us, part of our life, there was no stroke intervention. But good news is now there is 2 options. So depending on what kind of stroke you're having and when you present to the hospital. So if you wait, you go to bed, try to sleep it off, wait till your daughter gets home to drive you in, you might not actually be in the time window anymore to get an intervention to reverse that stroke. Because like Chelsea explained, your brain cells are dying rapidly. And once they die, you can't undo that. But there is a time frame in the first few hours where they're not completely dead and we can undo it. But if you wait past a few hours, and we typically say 4.5 hours, then we can't reverse it at that point. But you can also get a mechanical thrombectomy up about 24 hours after the stroke has started. So we want you, if you're starting to have symptoms of a stroke, to call 911 immediately, because the faster you do that, the more time we have to figure out if you can get one of these interventions. So one is an IV medication. It's one that we push through an IV, 5 seconds, and it's done. The other one is a minimally invasive procedure where they go in through either your groin artery or your wrist artery. and they go follow the blood vessel up to your brain and literally go pull out that clot that's blocking that blood vessel. So they have a stent retriever that pulls that out. And you can see on this picture a picture of a clot that was pulled out of someone's brain, multiple pieces that were blocking that artery. And keep in mind, your brain arteries are very small. You know, they're not large, big, you know, honking arteries that if you get a little plaque in it, it'll just keep going through. These are, you know, and they get smaller and smaller the further up the brain they go. So keep that in mind. Okay, I want you guys to think about, where do you live and where do you travel? Can one of you guys tell me somewhere that's not Oahu that you maybe live or travel? Pick a place.
Kauai.
I feel like anytime we ask this, they always hit Kauai. So where are we in Kauai?
Waimea.
Waimea. Okay, sounds good. So you're up in Waimea, and you start having a stroke. Okay, where do you think you're going to go?
Kauai Veterans Memorial Hospital.
Yeah, I hope they take you there. That's what sometimes they bypass and go straight to Wilcox, but I want them to go straight to Kauai Veterans, because if you show up at KVMH, you're actually going to get a Queens neurologist on the camera who's going to look at you in their emergency department and assess what kind of stroke you're having. So here at Queens, we do telestroke. So we don't only cover our one hospital system. We cover multiple hospital systems, and 10 hospitals to be exact, and then we'll be getting Kuakini here soon, so we'll have 11. And what that means is, if you're having a stroke and you go to KVMH, then on a camera, our neurologist will come up and they'll ask you to like raise your arm and, you know, say a few words, and they'll ask you about your symptoms. They'll be assessing you with expert knowledge on strokes, so that they can figure out if you can get that IV medication when you're at KVMH, because KVMH has it, they can give it to you, and then you can be treated right there, versus driving all the way down to Wilcox and then starting that process. And Wilcox would have their own doctor, right? So they have their own system of how to run a stroke code. So you can see here in the navy blue are all the sites that our doctors cover telestroke, and then the other colors have their own stroke doctors or care. And at every single one of these hospitals, you can get that IV drug. So we don't want people to worry about where you are when you are having a stroke. We want you to just go to the nearest hospital. Number one, we want you to call 911 because they will triage you to the most appropriate hospital. So all those hospitals can give that medication, but there's only one hospital that's capable of performing that secondary intervention where they go in and pull out that clot. So this is a type of stroke where half of your brain is dying. This is what we call a large vessel occlusion, where maybe your carotid artery comes up and it branches, and then there's a clot in one of those branches. So the best treatment, the gold standard treatment for that, is to go in and pull that clot out. So we have, a system in place with all of these hospitals to assess for that kind of stroke. And if they identify that stroke is happening, we have we've set up a system where then you are taken, flown over to Punchbowl, or if you're on Oahu, you'll go through the EMS system so that you can get that care as soon as possible. So on Oahu specifically, back in October 2019, we made a bypass law that helped triage people who are having that kind of stroke, that big, large vessel occlusion, that needed thrombectomy. So now, even if you're picked up in Haleiwa and you have multiple options, right, coming down, you've got Wahiawa, you've got, you might have even maybe gone over to Kahuku. You can go to Polimomi. There's multiple options on the route that the city and county EMS can take you. But if they perform these certain exams called LAPS and CSTAT. And if you're LAPS positive, CSTAT positive, that means that you're probably having a large vessel occlusion. So then they go ahead and take you straight to Queens Medical Center to decrease the amount of time it takes you to get to us, because we're actually the place you need to go. So that was implemented back in 2019. And so I kind of want to show a case study of one that happened in Hilo. So this was in March of this year. This patient was actually in the hospital for a foot wound. This was not someone who walked in with a stroke. So this patient was already hospitalized, had dressings to their foot, this special vacuum machine we use for wounds. And the nurse had seen the patient 15 minutes before 10 a.m. At 10 a.m. comes back and finds that the patient is having symptoms. So the patient is having left-sided weakness and is, not talking. So the nurse activates a stroke code immediately. The team comes in, our doctor gets on the camera. They take the patient to CT scan, make sure it's not a bleeding stroke. And they give the patient, within the symptoms of finding out the patient was having an issue to the time the patient received the treatment was 28 minutes. So that's super awesome. That's what we want. And then they did this exam, this study called a CT perfusion study on the bottom left, where the left side of the brain shows if there's any stroke that is permanent already. So I don't see any pink on the left side of the brain, on the left images of the brain. On the right side, the green tells me that all of that area is going to die if we don't do something. So half of that person's brain was about to die if we didn't, give that T&K, and if we don't bring them over to Punchbowl to get a thrombectomy. So they look at the scan, they go, okay, send that patient over to us right away. So there is a time elapsed with these transfers. And one of my goals is to get these numbers down to decrease this 4-hour transfer time from Hilo to us. But within arriving at Punchbowl at 2:08, 9 minutes later, the patient is getting that clot pulled out, because we are waiting for those patients. We are ready. We have our system down, and we are, we're like, get them in right away. We do everything, get it, figured out, and start pulling out that clot. And you can see on their MRI scan in the middle that little white dot, it would have been the entire half of that brain would have been white. And honestly, someone can die from a large stroke like that. But instead, they just had this tiny dot on their MRI, which to me is a win. This patient went from being very disabled to having almost no disability. And oops. I'm trying to move this so I can see it. So the only thing that this person had was a little left arm weakness left. That was all they had, but they had started with left-sided weakness.
Can I ask a quick question?
Yeah.
So when they get the TNK, how long before you know if it worked to determine whether or not they're going to need to get on that helicopter and come to Oahu?
So the TNK can start working immediately. It only works in about 20 to 30% of people. So we don't wait to see if the TNK works. We give them the TNK and they immediately do the scan, this next study, that green one. And if we see on that scan that they have that large area, then we just go ahead and say transfer right away. And then they come to us. And if they come to us and we see they're all better, then we would scan them again to make sure that it's, fine. And then we wouldn't take them to thrombectomy. And we've seen that happen a few times, but we err on the side of caution and the side of just bring them over and we'll take care of them, whatever, shape they're in once they're here.
Thanks.
Yeah, no problem. Like I said, our goal is for anyone to be brought to the nearest facility and receive the same, exceptional stroke care. So as promised, we want to make sure you know how to recognize a stroke. So I want, I know a lot of you guys are on mute, but talk out loud. We're going to go through what BFAST stands for. So B is for balance. E is for eyes. So that's vision changes. Double vision, blurry vision. If one eye suddenly can't see anymore, or you can't see that side of your vision. F is for face, drooping. A is for arm weakness, or you can have just leg weakness also, but I don't think L works in this acronym. And then S is for speech difficulties. Someone who you're like, they don't make any sense anymore, or they're slurred, or they're just, talking nonsense, or they're not talking at all. They've just stopped talking. Then we say T is time to call 911. So I want to explain why these are the symptoms. So for the B and the E, because we used to teach FAST, we used to just teach FAST, but we've added on the B and the E, which is balance and eyes. Because some people can have strokes in the back of their brain. That's the posterior circulation, back of the brain. And that's the area that helps us stay balanced and the area that helps us with our vision. So that, if that area is the area that's dying, that's why you would see balance issues and eye problems. You wouldn't necessarily see any face, arm, or speech problems. But if you were having a stroke on the side of your brain, that's when you would start seeing that face, arm, or speech problems. Or if you're having deep strokes, really inside, deep brain strokes. So this is like, this is just like high tech. I don't even memorize all this. Saying, your vision, all these pathways happen in different areas. And so a lot of these posterior circulation, our doctors going, which side is wiggling, checking the vision in all the fields because they're looking for this to see where you might have vision loss. And then something called CRAO is where the central retinal artery has the clot in it, and that shuts off the vision in one eye. So sometimes the eye doctors actually who sends these patients to us. Because someone goes to an eye doctor and says, I can't see out of my left eye anymore. And then they look in there and they go, you need to go to the hospital, you've had a stroke. So that's more for the posterior circulation, the B and the E. Then for the face, arm, and speech, if you can see in this brain with the red area, there are speech centers in our brain. And the MCA is the middle cerebral artery that feeds that part of the brain. It sends the blood there. So if that artery gets blocked, then you would have speech problems. You would also have face drooping and arm weakness. In this other picture where this guy looks wonky and his hands are huge and his mouth and tongue is huge and his genitals are a little exaggerated, it's because it's trying to explain that these parts of us require a lot of nerves. They require a lot of brain cells. So, to do little fine motor skills and to talk requires a lot of nerves and brain cells. So oftentimes that's what gets knocked out during a stroke. And those are the symptoms we see. We have these strips right along our brain, the motor strip, which controls your arm, your speaking, controls your legs. Any questions on this part?
So if you have some kind of brain injury in that part of a certain part of the brain, it may affect that just based on this picture here, yeah?
Yeah, so sometimes we
Mm.
were like, oh, they just had a hand, like a hand knob sign. So like just the hand portion was affected.
Mm.
Or they, if it's the artery that kind of feeds this middle mohawk area, then maybe just their leg is affected. We come in and we're like, oh, only their leg's not working. So then we know it might be this ACA artery coming down this way. But if someone comes in and they can't move one side of their body and they're not speaking, we know it's probably a big stroke, and we need to find out if it's a big stroke or a deep stroke.
Mm. Mm-hmm. Mm. Thank you.
Yeah. Okay, so unmute yourself and tell me what BFAST stands for. What is B?
Balance.
Yeah. What is E?
Eyes.
Perfect.
Eyes.
What is F?
Face.
Yeah, face drooping. What is A?
Arm.
Arm what?
Can raise it or not.
Yeah, weakness. Yeah, you can't use it like you normally can. And then S?
Beach.
Beach.
Yep. And then T?
Time.
Call 911.
Yeah. So what do you do if someone's having a stroke?
Call
Call
911.
911.
Yes, call 911. And once again, to reiterate why, there's multiple things. Number one, we have laws and triage systems in place to get you to the right place. Number two, they call us ahead of time when they're in the ambulance, say we have a stroke coming. So my team is waiting in the emergency department for you. If you come by car, it takes time for them to realize it's a stroke, and then they call a stroke code. So there's a delay, right? Number three is they already have that IV in you. They're putting an IV in you when you're coming over here, and then we can just give you that medicine as soon as the CT scan says it's okay. So those are the main reasons, I would say, to call 911. Okay, that's it. That's what I got for you.
Mm. So Danae, if it's a blackout, like if people black out and don't remember, is that a part of what you just described? Because I know you said balance, but not really blacking out.
Yeah, so if someone like passes out and regains consciousness,
Yeah.
it could be stroke is one of the things it could be.
Mm.
There are other things that could be,
Mm-hmm.
but it is a sudden. So stroke is a sudden attack.
Yes.
Some people, the first sign they have is they do just black out and fall, and then they might realize that they can't speak or they can't move their arm.
Right. Okay. And they should check with the doctor right away.
They should call 911.
911. Mm-hmm.
Yeah.
Okay.
So it's not normal to black out anyways. So even
Yeah.
if it wasn't a stroke, you want to figure out why, because then it might be heart related.
Yeah. Mm-hmm. Mm-hmm. Thank you.
It's a good question.
Did anybody else have a question for Danae? She is like a stroke master, and she's at your disposal right now. So you want to take advantage in case you had any questions.
Mm-hmm. Adele, were you trying to say something? No? Okay. Because you're muted, so I saw your lips moving.
I said strokes are scary.
Oh. Mm-hmm.
And neither one of us in our presentations mentioned it this time around. But if you remember from the first time when we did the presentation, strokes are like, what is it, Danae, 90%?
It's like 80% of them are preventable.
And that's why the stroke risk factors and getting your stroke risk level down is so important, because it's something that you can do. You saw out of the 8 risk factors that Chelsea shared, the only one that we can't change is our family history. So that's why we can do something about it. We can get it down and we can make it be not so scary. Because everything that you do is, you know, even if it's just a little thing, not having that extra dessert or not having, what is the Filipino lechon, right? People love that stuff. You know, maybe you are used to having it every week, but maybe you only have it like once a month. So you're not depriving yourself, right? You're just cutting down, because every little thing contributes to your stroke risk level.
Is lechon, it has a lot of fat? Is that why you're mentioning that? You know,
It's kind of funny because everybody
salt.
talked about it, how good it was. So I went and got some
Mhm.
because I'd never had it. And
Yes.
then I came back to work and I said, why do you guys think this thing is so great? It was all fat. I had to cut it off. And they're like, oh my God, that was
So-
why you buy it. Oh, okay.
Yeah, I would, you know, something we teach the Mediterranean diet that's what's proven to prevent stroke. And what the Mediterranean diet is, it's just eating a lot of fruits and vegetables, cutting down on your red meat. It's exercising and having community, you know, eating with friends and family, having that sense of well-being, having more fish. And something that like my husband and I are talking about it, and it's like, you know, people, if we eat these other foods, we, you know, a lot of fast food and less vegetables, that we're not only getting foods that build more plaque in our arteries and raise our high blood pressure, we're also not eating the foods that help prevent it, you know, so it's like a double whammy, because the fruits and the vegetables, they have like minerals and things that you can't take through vitamins in it that actually decrease the inflammation in our body. And our blood vessels, if they get inflamed, that's when it starts building the plaque and building clots and things like that. So if we're eating poorly and we're not exercising, if we have diabetes and our blood sugar levels are high and just scraping up the blood vessels, the blood pressure is high, you know, putting a lot of pressure in those blood vessels, then that's when they start to get damaged and, you know, you develop risk for a stroke and heart attack. So just keep in mind that these things are just healthy for you, and they actually are going to help prevent lots of other diseases. Go ahead, Adele.
You talked about mini strokes, how they could be a sign of a big stroke to come. So how do we know if we've had a mini stroke or a series of mini strokes? Do they have symptoms like the face, the vision, or?
Yeah, they present as a stroke, and to start with. The difference with a mini stroke or a TIA is that the stroke doesn't complete. So you would have those symptoms, the BFAST symptoms, but maybe in 10 minutes they go away. That means that blood circulation got back to your brain, and so it didn't cause permanent damage. Where an ischemic stroke is permanent damage seen on an MRI. So if you had a mini stroke and I did an MRI, like you had symptoms and it went away, and I did an MRI, you wouldn't have any strokes on your MRI. It would be like negative. But the symptoms, you know, because you maybe came in with that weakness or you're not talking, tells me that something's going on in your body that blocked up that blood vessel for a short amount of time. But eventually, if, you know, things don't change in your life, you're not on the right meds, you would have a blood vessel that's blocked permanently.
I'm wondering at Lanakila, have you folks, you know, because there's a lot of seniors, okay, and people are having strokes younger, but typically when you think of strokes, you think of our seniors, right? Has anyone coming to Lanakila ever experienced a stroke at Lanakila and then you guys had to call 911 or get them help?
Not in our history, and I'm knocking on things. But I know there are members that have had stroke. Normally, I'm not too sure if they're at home or, but that's why we really want everyone to know, and I'm glad this is being recorded so as many members can hear it, what you're saying, and sharing with their family members and friends as well. So thank you. Michelle, did you
Those-
have? Mhm.
Those members that had strokes, were any of them able to return to Lanakila to participate in the activities?
Yes.
Did
And
they share any stories about their stroke experience?
yes, but we can't share them.
Oh yeah, of course, sorry.
Yes, they have. And I believe in a number of cases, the activities that they're doing at the center or online from the center has really helped because of the exercise, yeah, the physical activity, the information that they receive from these types of presentations are very helpful. And I know a number of members who have tried to help their family members and friends. You know, I know a lot of our members, they email what they receive to all their friends so they can learn as well, even though they're not members, or they'll talk story, at different gatherings about what they've learned. So what you're doing now will impact many people. Mhm.
Jack, I see you're unmuted. Did you happen to have a question for us?
Yes, you mentioned about the hospitals. You didn't include St. Francis or Joaquini. Does that mean they're not as well prepared or equipped to handle stroke cases?
So Kuakini is part of one of the ones I mentioned. I'm not as familiar with St. Francis because when I moved here, my understanding was there was a St. Francis that is now West Oahu. Is there a different St. Francis that's still
There's
around?
a Liliha, St.
Lily
Francis.
has St. Francis, but they don't have emergency room or hospital anymore. They did for many years. They do have long-term care related facilities and wellness center services now. Mhm.
Gotcha. So Kuakini would potentially be the closer hospital than with an emergency department. And they have their own neurologists covering their stroke codes right now, but their neurologists are no longer going to do that. So our team is in the midst of talking contracts and taking over that.
Thank you.
Yes, thank you, because both of what Jack mentions is in our neighborhood. So I think
Okay.
his concern is, do we have anything close by? I know you didn't mention Maluhia, but as a long-term care facility, there's nothing like that, right? That they're part of the health Hawaii Health Systems Corporation.
Yeah, if they're not an emergency department or like
Yeah.
a critical access hospital or higher, then it's not likely that a stroke code would show up there. If they have a member who is residing there that's having a stroke, they would call 911.
Yes. I wonder if at some point, because of the timeliness of a response, if there is any work to connect our urgent care centers across the island and other islands to this kind of access for assessment. Because with technology, it's possible, I would think.
So the issue with urgent care is like if it's just like a walk-in urgent care is a lot of them don't have CAT scans. I don't actually know of any that have a CT scan, and that is the first step in getting the treatment. So that's still where we don't want people to go to an urgent care if they're having a stroke. We want them to call 911 because you need to go to a hospital with a CAT scan, and that's prepared for stroke.
Yes, I know there's a different tide of trying to prevent going to emergency care, emergency services at the hospitals. And if people are not familiar enough with the stroke signs, they may go to urgent care. So I just wonder if there is at least that connection where maybe a physician there or a healthcare professional would know it from their vantage point. It seems like a stroke, and they can connect immediately to get at least that visual assessment until an ambulance or someone can pick them up to go to the emergency room.
So we're getting closer to that. That's really good. I like your project improvement thought process of how can we make it better. We're getting closer to that. So what typically happens now is an urgent care, one of their physicians there recognizes this is a stroke. This is not for us. They call an ambulance. We are in the midst of setting up our ambulances with a video conferencing technology, so that in the rig, they can talk to the neurologist, but it does still require the ambulance rig getting there. But hopefully that happens in a short, few minutes. But then they would have on that rig immediate access to a neurologist through that camera. So yeah, we're actually in the middle of, we got a grant to fund for that technology to test it out for the next few years. And there has been a lot of, we've had to check with the community, make sure they feel comfortable with that kind of technology. And we have a whole team working on that. So that is
Wonderful.
yeah. So within this year, we'll be seeing it on Oahu. We'll start, and then we'll branch out to the neighbor islands as we get that process down.
So once that process is established, I would think even for primary healthcare centers, if something presents like that, they'd have that same access with the ambulance
Yes.
rig, having that immediate. Very good. Thank you.
Danae, I received another question. Is the treatment same for both kinds of strokes? When we hit our head on something, should we go in to check?
Okay, so for the two kinds of strokes, a bleeding stroke and an ischemic stroke, so hemorrhagic versus ischemic, the treatment is opposite. So that's why we do that CT scan first, because the CT scan will show blood. So if we see blood on that scan, we know you're having a bleeding stroke. We're not going to give you a blood thinner, right? But if we see no blood on that scan and we see your symptoms, then we know it's safe to give you a blood thinner, that IV TNK, that big breaks up clots. So the treatment is different. So if you come in with a bleeding stroke, there's technically no treatment except for blood pressure control. We want to get your blood pressure down so that blood vessel that's open can kind of scab over and stop bleeding out. And then we manage you, to get you through that tough time. We are part of a trial that's starting for a drug to try to slow down and stop bleeding brains if you come in within 2 hours of it starting. It's a very short time frame. So recognition is even, greater, needed in the community so that you come in fast enough, because if you are having a bleeding stroke from high blood pressure or meth use, which causes high blood pressure, then there is a potential for this drug that you could get as a trial basis. We're part of a trial here at Queens. And then for that second question, when you hit your head on something, should we go in to check? I have to say yes. So hitting your head is trauma, and I'm not as familiar with brain trauma as Michelle and Chelsea might be. But from a medical standpoint, I have to say yes, because sometimes it's really bad. And sometimes it's not, but I have to say yes. So
I know for our senior center, the practice is to encourage our members, if they fall and at all hit their head, to contact their doctors right away.
okay.
We'd rather err on the side of caution, and we encourage people to do that.
Yeah.
I don't know if Michelle and Chelsea, you folks have anything.
Chelsea, do you have the number on the statistics on falls? How many end up going to the emergency room? Do you remember? I know it's really high, and especially for the age group that we're addressing here. Well, you know what? While Chelsea's looking for that, we have one more question. Is a heart attack a stroke, but in the cardiac arteries?
So, yep, that's basically, you've got it, Marilyn. We see it's a brain attack because it's the same mechanism. It's a clot blocking an artery, but that artery just happens to be in your brain versus your heart. So it's exactly the same. And you can't really live without one of them, right? Can't live without your heart and can't live without your brain. So
Thank you. Very good. I know the other thing, if someone falls, besides checking with their doctor, we have been told to try and have them not go to sleep, to be able to check first and not fall asleep. Is that still best practice, or the recommendation we should be making to our members?
I would say yes. You want to make sure that you don't fall asleep and then, clot forms or you bleed out, right? So you want to make sure you know what's going on first.
Okay, thank you.
Danae, that was a lay person's explanation.
yeah, no, I mean, I think the idea is correct that you want to assess the patient. So if they go to bed, you can't assess them. One of the signs that, like, say you hit your head and you start bleeding on that outside part of your skull, but under your skin, it is decreased alertness. So one of the signs that something is happening is someone who starts to get really sleepy, and it's not, and maybe it's not your normal sleep time, but yeah, I think, but I mean, don't keep them awake for days. Because your brain does heal while it sleeps, but yeah, like if you can make sure they're okay, or if you notice over the next few days they start changing, or personalities a little bit, are getting sleepier more than normal, or any neurological issues you see, changes in their arms and any part of your body, our brains are computer, so if any part of your body changes, then just go seek medical attention.
Is that what Bob Saget's death is attributed to? A head injury? The comedian who
Bob Saget.
Yeah.
They didn't really give details. All they said was he hit his head. He went home. He did a show. He went up to his room. He hit his head and then he went to sleep. So they're thinking he didn't think it was that bad, and he would just sleep off the pain. But whatever happened, right? He didn't make it, unfortunately. Danae, one more question. Would brain bleed cause any nose or ear bleeding?
No. If you have you can have this weird sign of bruising in the back of your skull from some type of traumatic injury. And this is going back to my nursing school days. So I don't remember what it's from, but that's a really bad sign. If you have if you hit your head and then you have bruising behind your ear. Bleeding from your ears, I honestly don't remember why that happens. I'm sorry.
We didn't have access to, quick access to that falls data. But Susie, aren't you guys running a falls program right now?
We have Tai Chi for Health, which is a fall prevention program. It actually is evidence-based to increase the strength of your core. And so a lot of folks, when we do our sit and stand tests, Iris Hiramoto, our membership specialist, does a sit and stand test and a mini cognition test for the purpose of prevention. So if we notice that the scores for sit and stand may not be good for that person's age, we often recommend that they try to get involved in the Tai Chi for Health class. And for many who just want to keep strong and maintain their core strength, that is a very good class to take at our center.
But didn't Matter of Balance, that program, didn't you folks have that?
We trained and had, I think, several classes, matter of balance classes. We have not had it since the pandemic. So
Ah.
we have not scheduled any at this point. We do hope to resume the matter of balance classes, which
Is
is
it
also
Catholic?
evidence-based.
Is it Catholic Charities that are trainers?
Yes, we, several of us, I think some of our staff, myself, and there are other supervisors and social workers that went through the training. I'm sure we have to get a refresher because it's been almost 3 years now. But that was our hope, that we would have the matter of balance class offered. It's several weeks long in order to make sure our members and those that, you know, participate. I think there were people outside of the center that wanted to join us, and that's where we were at. And then the pandemic hit, so we didn't have another set of classes. But I'll ask Peter Reyes. He is our lead on the matter of balance program.
We've kept you folks actually about a half an hour over, so we're so sorry, but thank you
Oh, thank
for
you.
making this so interactive. Jack, did you have another question before we left?
Well, I just wanted to say, you know, I had what they call subdural hematoma. And, you know, the doctor kind of said, "Did you hit your head?" And I said, "No." But what happens in this case is that inside the brain, there's bleeding, hemorrhaging. So they had to go in and take out the blood to release the pressure on the brain. So it was a kind of, for me, I didn't think it was a touch and go situation, but I guess it could be. But, you know, you just got to be careful, not because you hit your head, but it just happens sometimes.
Are you okay now, Jack?
Knock on wood, yes, I haven't had instances, so yeah. So, but, you know, I've always had that dizzy thing, so I got to be careful.
Yeah, me too.
Mhm. Well, thank you so much.
Yes, thank you. Any other questions before we go? I
Nope,
cannot
thank you.
thank you guys enough. If you have any questions about the recording, once we, you know, release it, I'm gonna try and see if I can close caption it. I don't know if I can, but you'll get it either
All
way.
right, thank you. Now, as a follow-up, Michelle, are we doing this on an annual basis so that we can track our, or is it just a 2-year kind of program that you've developed?
You know, we were just sort of playing it by ear.
Mm.
Susie, if you want to take some kind of a poll and find out if people want to do it for another year,
Mhm.
we can do something. We can, you know, get together and figure it out, because
Okay.
it would be nice to get something regular going and people can join or drop off. Well, we hope that they stay,
Yeah.
you know, at will, right?
Okay. All right. I will do a survey of our members and then get back to you.
Thanks so much.
Thank you.
Thank you.
Thanks, you
Thank
guys, for
Bye,
your
and
time. Thanks for
Chelsea.
being
Bye.
here.
Thank
Thank you
you.
so much.
Thank you very much.
Bye.
Yeah.
Thank you.
Have a great week. Oh,
You
thanks, you
too.
guys.
Thank you.